Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Rectal cancer mortality rates in adults under 45 in the United States are rising up to 3 times faster than for colon cancer. A doctor at Upstate recently presented research about this trend, and she's my guest today. Dr. Mythili Pathiyil is a doctor working on a fellowship in gastroenterology at Upstate. Welcome to The Informed Patient, Dr. Pathiyil.
Thank you so much.
We often hear the term colorectal cancer. What differentiates colon cancer from rectal cancer?
The most obvious difference is just anatomy. The rectum basically consists of the distal 16 centimeter of the large intestine. When we say colon cancer, what we mean is all the rest of the part of the colon, which is the ascending, the transverse, sigmoid, descending colon. And the location alone affects how these cancers present, spread, and how they're even treated. And both the colon and the rectum, they arise from different embryological origins during development, and that contributes to different molecular and genetic profiles between both colon and rectal cancers. And what it means is that the treatment options varies as well.
So there are different cancers, if I understand you, and the rectal cancer's in the lower part, the small part at the end, and then the colon cancer is everything above that.
Yes, exactly. So rectal cancer is just a distal 16 centimeter of the large intestine, and that sits in the bony pelvis region.
Gotcha. Now, how common is colon cancer compared with rectal cancer?
Colorectal cancer approximately accounts for 1.9 million new cases annually. It's the third most commonly diagnosed cancer, and it's the second leading cause of cancer mortality overall. And it's the leading cause in adults under the age of 50 years in the United States for cancer-related mortality. The colon cancer constitutes the larger fraction of the colorectal cancer cases. Historically, rectal cancer was known to constitute around 27% of all of colorectal cancer. But now this proportion has been increasing, and it's more dominant in younger adults, like in individuals below the age of 50. Rectal cancer constitutes around 41% among colorectal cancer. And rectal cancer now, we know that its incidence is increasing annually. It's almost increasing by 1% annually. And even though overall the colorectal cancer incidence has been slightly declining, that's mainly driven by the decreases in older adults as compared to younger ones.
So is there data to show which is more deadly, the colon cancer versus rectal cancer?
I think in terms of which is more deadly, both can be comparable. It's just the key would be what stage it's detected in. Both colon and rectal cancer, when detected early, it improves its outcomes. The survival rate is higher. But when it's detected later, that's when the mortality rates increases. And we have data that shows that in individuals less than 50 years old, when rectal cancer is detected, it's almost already in stage 3 and 4, which is advanced stages. And that in itself can be the reason why there's such a rising mortality rate of rectal cancer, in particular in young adults.
So the key is finding out or detecting it early.
Exactly. Early detection is key in improving outcomes.
Now, the American Cancer Society reports that the incidence rates of colorectal cancer have been dropping about 1% each year since 2013, but mostly in older adults. And the group says that rates in younger people under 50 have been increasing by almost 3% per year during the same time frame. Your research backs that up, is that right?
Yes, it does. So our research basically just builds on this and extends those findings from the American Cancer Society. While they show that the early onset colorectal cancer incidence is increasing under the age of 50, what we looked into is whether incidence alone does not really tell whether people are actually dying from the disease. So you wanted to mainly look into that, the mortality rates, and look into which populations were affected and how these trends would evolve in the future. And that's one of the reasons why we undertook this study.
I saw that you used death records from CDC Wonder. Can you describe what that is?
Absolutely. So CDC Wonder, which is a database from the Center for Disease Control and Prevention, it's just a large publicly available national database that compiles death certificate information from across United States. So because it captures the mortality data from the entire country over many years, it's one of the most comprehensive tools that's available if you want to look into long-term public health and disparities.
Well, let's talk about your findings. What are the rectal cancer death projections?
So the total rectal cancer projected deaths in 2035 was estimated around 750. That is around 450 in males and around 300 in females. And colon cancer death rates was around 1,500 in the year 2035, which was approximately 830 in males and 670 in women. The absolute numbers might seem small and modest, but the concern is that the direction, the consistency, and the acceleration of these mortality trends, especially in this young population where you expect the mortality should be falling given this age of advances. This is why this is a significant and emerging public health concern, despite the numbers appearing pretty modest at first glance.
Are rectal cancer rates rising across all demographic groups equally?
They are rising across all demographic groups, but not equally. Our studies showed that in Hispanic adults, we saw that they had the highest increase in mortality rate. White individuals had sustained rises, and rectal cancer rates were also increasing among Black individuals and Asian adults. But while it was rising, it was not as steep as those compared to Hispanic adults.
What about geographically across the United States? Are you seeing any pockets of concern?
We are actually. We saw that the Western United States had the steepest rise in both colon cancer as well as rectal cancer. The Northeast actually had declining colon cancer mortality rates, but rectal cancer rates were still increasing there. And the Midwest, South, all of the other ones showed increasing both colon cancer and rectal cancer mortality rates, but the steepest was in the West. And we suspect that could be likely because we looked into mainly the young population below the age group of 45. Maybe that's the concentration in the Western United States. We think that might be one of the contributing factors.
We talk about this being a concern for people under 50. How young are you seeing this in? Are we looking at people in their 40s, 30s, 20s?
When we looked into age-specific trends, what we did is we split them in 5-year gaps. So we looked from 20 to 45. The main burden was among older young adults, that is between 30 to 44. That's where the steepest rise was. We found that colon cancer mortality actually declined in ages 20 to 24, and rectal cancer mortality declined only among the ages between 25 to 29, but among all the other age groups below 45, it was rising. But the steepest rise was among 30 to 44, which was almost 2 to 3 times more than colon cancer mortality rise.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking about rising rectal cancer rates with Dr. Mythili Pathiyil. Now, the big question is why? Why are more younger people being diagnosed with rectal cancer?
The honest answer to that is we do not yet know. There's been no single predominant cause that's really been identified. There's evidence that shows that it could be just early life environmental, dietary, and metabolic exposures. And also, most of these early onset colorectal cancer cases are sporadic, which means it's not hereditary. So that's why we suspect that maybe environmental and lifestyle factors are possible primary suspects. But there's not been any single etiology or predominant cause that's really been identified based on all the studies that we have done. There is data that shows that there's diet-driven gut changes and chronic inflammation, factors that are linked to obesity, sedentary lifestyle, ultra-processed food, metabolic syndrome. These might be possibly associated with colorectal cancer. Again, these are just associations, but no real causative link has been found yet.
Well, we talked earlier about the importance of early detection. So, what are the symptoms to be on the lookout for?
Absolutely. Some of the symptoms include rectal bleeding, persistent abdominal discomfort, altered bowel habits. That means changes in bowel habits, and iron deficiency anemia that's found in the lab work. And the presence of multiple symptoms simultaneously, they increase the likelihood of colorectal cancer as well.
Now, I know that rectal bleeding doesn't always mean cancer, certainly. How do you differentiate blood from, say, hemorrhoids from blood from a cancer?
That's really a great question, mainly because, like we mentioned, early detection is key for improving outcomes. And we already have data that shows that 3 out of 4 in younger adults with rectal cancer are diagnosed already in their advanced stages. And that could be because of just symptom misattribution or just systematic healthcare delays. And some of these symptoms like rectal bleeding, it's tough to differentiate, to be honest, because the bleeding pattern is pretty non-specific. When you have additional symptoms like abdominal discomfort, unintentional weight loss, lab work showing iron deficiency anemia, the likelihood of colorectal cancer, the risk increases, but it's very important to get evaluated and not just brush off symptoms to just stress or hemorrhoids without proper evaluation, especially given that rectal cancer is rising right now and clinicians are aware of that as well. A simple examination, like a rectal examination, can differentiate and see whether, hey, is this coming from hemorrhoids? Is this something benign that we don't really need to worry about? Versus, hey, is this something we need further workup with a colonoscopy or flexible sigmoidoscopy? So just not brushing off any symptoms, making sure that you talk to your primary care physician and they decide if you're required to be seen by a specialist like gastroenterologist or not, just not brushing off any symptoms. That would be most important.
If someone is suspected to have, they've got rectal bleeding and maybe some of the other symptoms you mentioned, what more is done to diagnose whether it's a cancer? Do they automatically go for a colonoscopy? Is that the next step?
Yes. So usually once there's any sort of suspicion for colorectal cancer, the next step would be a diagnostic colonoscopy. What it does is it's a direct visualization. It looks into your rectum, your colon, and if there is anything that looks suspicious, we take biopsies of the same and then go from there.
And then what are the treatment options for someone with, let's say, rectal cancer? What may lay ahead in terms of treatment for them?
Rectal cancer is a little different in terms of treatment compared to colon cancer because colon cancer is predominantly surgery. Like surgical resection can be curative in early stages, and in more advanced stages, we consider adjuvant chemotherapy as well. Rectal cancer is usually more multimodal. We think about neoadjuvant chemotherapy, radiation therapy, and then it's followed by surgical resection. The more complex multidisciplinary approach is needed at that point, but it depends on the location of it and the type and the mutations that's seen and further.
You said that rectal cancer is driving much of the increase in colorectal cancer and that it's likely to worsen over time if we don't change what we're doing right now. So, what are we doing and what needs to change?
Right now, what we're doing is we're screening most average risk adults, that is, individuals with no family history of colon cancer. They do not have any concerning symptoms. We start at the age of 45 with the colonoscopy, and then we repeat it every 10 years if the colonoscopy is negative for any concerning polyps or anything. Or we do stool based testings, and if it's positive, then we follow it up with the colonoscopy. This is appropriate and it's evidence based, but it leaves a gap because most of this population that we looked at in our study falls under 20 to 44 years. They're too young for this routine screening and under this current average risk guidelines. But does it mean that we have to scope everybody who's younger? Not really. We just need maybe earlier symptom recognition, especially for symptoms that we spoke about, rectal bleeding, change in bowel habits, lab work that shows iron deficiency anemia, unintentional weight loss, or persistent abdominal pains or rectal symptoms. These should not just be dismissed as hemorrhoids or IBS, diet, or stress related changes without the appropriate workup. So we need risk-based earlier evaluation for people under the age of 45, especially with family history of colon rectal cancer, concerning symptoms, or those who have had repeated healthcare visits for GI complaints. And because the rectal cancer appears to be rising sharply, even clinicians need to have a lower threshold for just direct rectal evaluation, including the colonoscopy or flexible sigmoidoscopy that we spoke about. These findings basically highlight the importance of both public and clinician awareness that, as we mentioned, early detection is key to improving outcomes. So it's less about just changing guidelines overnight and more about just being cognizant that colorectal cancer is now seen in younger adults and rates are increasing, and it just needs earlier attention.
So, making sure physicians certainly are aware of this, but also it sounds like patients need to bring this to their doctor's attention. Otherwise, how would they know
Exactly.
necessarily?
Exactly, because sometimes we think that you're too young for cancer. If it's a 30-year-old having rectal bleeding, most likely it could be because of constipation and hemorrhoids, which most likely it could be, but it's still important to bring it up with your primary care physician, get a rectal examination done, because there's been a lot of studies that's been done that shows that around 45% of around 1,000 people who were sent to the hemorrhoid clinics did not really have hemorrhoids. So it's just a simple rectal examination that can differentiate whether this is really something benign or something we need further evaluation for. So always bring it up with your primary care physician, and then we kind of go from there.
I know you said that most of these cases that you're seeing, the increased number of cases, are sporadic, But are there factors that increase a person's risk for developing rectal cancer?
That is tough to say because we still don't know what the predominant etiology of the colorectal cancer is as of now. But and like I mentioned, there are studies that show that diet-driven gut changes and inflammation, which have all been linked to things like obesity, sedentary lifestyle, ultra-processed food habits, that has shown some association with colorectal cancer. Whether it causes it, we're not sure, but there is some association. So with the information that we have, I think avoiding that would be our first mainstream things that we could do. There's also studies that shows that changes in circadian rhythm, like sleeping late, waking up late, things like that, has also shown some association with colorectal cancer, especially rectal cancer. So again, these are just association studies and not really causative, but this is all the data that we have as of now.
Well, very interesting. Dr. Padil, thank you so much for taking time to share your research with us.
Absolutely. Thank you so much for having me.
My guest has been Dr. Mythili Pathiyil, who is a gastroenterology fellow at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.